there's more to come. So hello everyone and welcome to today's live session. And I believe this is the last session of this training towards building resilient health system with primary healthcare. This is part of the course iteration where the Institute started during the COVID-19 pandemic, and it has now progressed to, learning from the COVID-19 pandemic and then using those learnings and creating a resilient primary healthcare system. So, hello everyone, my name is Frehiwet. I'm just here to say hi and welcome everyone to this course. We also would like to thank everyone who collaborated on this course since the beginning, including the Bloomberg School of Public Health, who were highly engaged since the development. So without further ado, let me introduce our moderator for today. Our moderator is Dr. Maika Schleif. She is an assistant scientist at the Johns Hopkins Bloomberg School of Public Health, and she has been a wonderful colleague and a good contributor of this course since the beginning, and she will be moderating our today's session. So over to you, Maika, and thank you, everyone.
Thank you, Fehiwat, and so exciting to see everyone here. I know it's been a great sort of collaboration and a big evolution for this course over the last 2 years or so during the COVID-19 pandemic. We've run this course collaboratively with the Institute leading the way, I believe 4 times now, something like that. And of course, we've added new content every time, and then have always had the pleasure of having these live sessions where we actually get to engage with you all, the learners, and also bring together some voices both from Ethiopia as well as from beyond and across the African region to bring some current perspectives and also to be able to discuss some of the ongoing challenges and decisions and complexities that health systems are facing and continuing to sort through COVID-19 vaccines, but also just thinking through the longer term of what needs to be sort of refocused on within health systems after this intensive focus on COVID, and thinking longer term, how can we do a better job to prepare for and prevent these kinds of public health emergencies in the future. So that's really the focus of today's session, thinking through how the primary healthcare systems in countries across the region have been leveraged and have really contributed to being able to respond to COVID-19, and then some of the thinking about the way forward. So we've got a fantastic panel of 4 speakers. It's going to be a lot of content, but we're going to make sure we save some time towards the end to be able to discuss across the panelists and also to hear questions from you all as the participants. So as we go along, please feel free to put questions, preferably in the Q&A section if you can, so we can kind of keep track of them, answer them there. You can also vote them up and down. So if someone else has already asked a similar question to one that you have, feel free to give it a thumbs up, and that will kind of move it up our priority list so we make sure that we get to it. So we're going to start with a set of presentations by the panel. So you'll get to hear more about their background, some of the important work they've been leading during the COVID pandemic. And then we'll move into a discussion phase. So I'm delighted to introduce our first speaker, Sarah Wanyoike, who is working at JPIGO as a senior technical advisor for immunizations. She has over 10 years of experience working on global health programs. She's done a lot of work on polio eradication, working with expanded program on immunizations, EPI, and also on the Global Polio Eradication Initiative. She's worked extensively across the African region as well as in the United States, and spends a lot of time working closely with countries across the region. So we're excited for her to provide a little bit of an overview of the region and some insights from from her work at Jhpiego. So over to you, Sarah, and thank you so much for joining us.
Great. Thank you, Micah. And hi, everybody. It's nice to meet you and a pleasure to see that we have a ton of attendees. That's very good. And I gotta say that as much as I'm presenting as the panelist, I'm actually really looking forward to learning from the participants on their specific country experiences, because I realize that we learn every day. So I'm just going to give a very short presentation. That's just an overview of an overview of where we are in terms of the COVID response and what are some of the basic learnings. And as you know very well, because I'm sure you're all working in supporting COVID response in one way or another, because what we found is people are getting repurposed from their day to day and find themselves having to manage something to do with COVID. So as you can see, I started with this map because I was just looking at how Africa is doing against the global performance, the global coverage with COVID vaccination. As you can see, the African region is actually a light green color, and the other countries are the darker green, which means we have more doses happening outside of the region. And we're still trying to catch up in terms of coverages. I think right now in the Africa region, we're up to about 24.5% of people having received their first dose of vaccine, but in terms of completing the series of vaccines, I think it's about 16% in the region. However, I think what has happened is over the last 6 months, we've seen market improvement. I think particularly after the Delta wave, which really claimed a lot of lives in the Africa region. I think initially the perception of risk wasn't very high because we were seeing more deaths happening outside of the Africa region, even though I think that it was happening in Africa, it just wasn't getting documented, because if you know people around you around December and January of 2019, 2020, there was some deaths that were happening that we really didn't know what was going on. Some people thought it was pneumonia. So I think there was a large number of deaths that have gone undocumented in the Africa region. So, but after the Delta wave happened, we saw that a significant increase in uptake in several countries. So as of July 31st, we've had at least 700 million doses of vaccine received in the Africa region in at least 46 out of 47 countries. I think the only country that's not there is Eritrea. They're yet to, I'm not sure if they've started yet, but the last I checked, they hadn't started the COVID vaccinations. And then a total of 216 million people in the Africa region have completed their primary dose of vaccines. That's about 18%. And then only three African countries, that's Mauritius, Rwanda, and Seychelles, have at least met the 70% target that was targeted for end of June of 2022. And then we have 6 countries that have recorded between 40 to 70% of completing the primary series of vaccine. And that's Mozambique, Sao Tome, Comoros, Liberia, Cabo Verde, and Botswana. And then 8 countries are yet to get to the 10%. I think we're still struggling in several countries, and it's of course because of several reasons pertaining to vaccine distribution in terms of access. And that's Burundi, DRC, Cameroon, Madagascar, Senegal, Mali, and Malawi. But please note that this is as of 31st of July, so those numbers might have changed. So overall, I was trying to see in terms of vaccine utilization in the region. So the vaccines that have been received, as you know, in the beginning, WHO and the COVAX facility came together to see how to bring, to leverage vaccine access in the Africa region. And through that, we received at least 66% of the doses, 66% of the doses received in the region are coming through the COVAX facility. And then of course, out of those, 60% of those have been used to actually vaccinate people. And so the question is, what happened to the remaining of it? What happened to, are we seeing expiry of doses, particularly in this time where we're starting to see, again, decreased uptake because the perception of risk from COVID is very low right now. After the Delta wave, and then we had the Omicron, and right now people are not seeing any deaths happening, even though I'm sure it's because of the testing. So we're seeing doses going unutilized from the health facilities, but It was surprising to me that we've only seen a 2.1% of the doses that have been received, only 2.1% of those have actually been reported as expired. But I think this was only reported from about 33 countries. And then I think the other biggest thing to note here is for the health workers, which was very interesting. I think 50.4% of health workers are fully vaccinated. So it would be interesting to learn from the group what your perspectives are on vaccine uptake among health workers in the Africa region. And of course, this information is available through the WHO Afro monthly bulletin that was released in July last month. Oh, last month, but one. Okay, so what have we learned from COVID and the pandemic and in terms of health system strengthening or building resilient health systems? So one thing to note is even before the pandemic, African governments were working to put in place mechanisms to improve the health system. We've had active engagement with the leadership, government commitments have been made, and then we've had in place some strong and comprehensive national coordination plans. And of course, new systems are being developed every day to see how to strengthen and make things that run a bit more efficiently, like the DHIS2 and some e-health records that are also coming up. Then over the past 2 years, a lot of efforts have been made by policymakers. Of course, this was necessitated by the pandemic. And then some more engagement between public and private sector players to rebuild human capital and strengthen health systems. And this is, of course, because of the impact and trying to recover from the pandemic. And also, in addition, there has been significant efforts made in the region to support local production of vaccines, given the spike in demand for the vaccines. I think one of the things we faced is that, and we can't go without saying that Africa has kind of looked like we've been the last in line to receive the vaccines that were available, because when the vaccines were announced that they're available, we watched other countries getting them and starting to vaccinate their populations. But then unfortunately, it looked like we didn't receive the vaccine early enough to start the response early enough. And I think one of the ways to address this is looking in-house within our African countries. Do we have that capacity to produce vaccines? And I can tell you from my little visits to the countries, I've seen the desire and the will, the capacity is there. So my question is, what's next? So during the pandemic, African countries also put together a few mechanisms or came together and decided to see about financing and supporting the pandemic through innovative financing approaches. So we have the Africa Medical Supplies Platform that came in, Africa Vaccines Acquisition, Africa Exports and Imports Bank, and all these people have been engaged through the Africa Union to see how to bring in more vaccines or to support local production of vaccines. So I think many of you might be familiar with WHO's framework for health system strengthening and the 6 pillars. So I didn't go into putting together all the 6 pillars, but I decided to just focus for purposes of this discussion and to stay within my 10 minutes. To focus on 4 key ones from my perspective that I think are very critical to discuss during today's presentation. One would be governance. Basically, how do we go about having more effective and participatory leadership and oversight from the highest level of government? Or is it even happening? And how, for countries where it's happening very well, and I know Ethiopia is one example, how have you done it and how can we learn from you? Then the other issue is coordination across government sectors and key stakeholders. So I think immunization particularly has been seen like it's a Ministry of Health mandate, and so they focus on it. But one thing we've learned is even the Ministry of Finance has to be brought on board, and the Ministry of Education has to be brought on board, and even Foreign Affairs have to be brought on board. I think COVID really showed how you really need all the players on the table when coming up with strategies. And then, of course, we can't go without talking about regulations and how requiring people to do some kind of either regular reporting, which could be quarterly or monthly, depending on whatever policies are in place already in the government. And then financing, which goes without saying, we can't do anything without money. And the question is, who pays for these vaccines and how do we go about making sure that they're paid for, or even who pays for that service? So ensuring that we have enough money available in the system committed to actually do some of this work, and then having effective financing policies and mechanisms, because we can have the money, but if we don't have the right mechanisms in place, it just leads to frustration and delays in how implementing activities. And then resources, having adequate human resources and physical resources, having the right surge capacity in place in the event of the need to scale up activities very quickly, as we saw in COVID, and then ensuring adequate amount of medical supplies, vaccines, and equipment. And then there's a service delivery, which to me is the biggest. Having context appropriate strategies, because what works, for example, here in the US, because someone reached out to me the other day and said, what is the US doing that we're not doing here in Namibia to vaccinate as many people as we want? But I think every country has its own unique context. And so one thing I always say is we have to have, and that's why my title was intentional, where I said local solutions to a regional challenge, because what works in one place may not work in a different place, but then we also have some cross learnings where you see something that might have worked in a different country that you might want to take and learn from it and maybe implement in your country. And then having a people-centered and opportunistic approach. And by this, I mean, like, as you've seen, like people who have HIV are having to go visit their doctor, at least for their regular appointments, maybe quarterly or once in 6 months. Are we having that conversation of, have you received your vaccine? Do you know you're at risk for COVID if you're immunosuppressed, or even diabetic clients, or even maternal and child health services? When moms are coming for their antenatal visits, are we having these conversations with them? When children are being brought in for their sick visits, are we looking at their vaccination status? I think those are some of the things that we started to be a bit more cognizant of and try to be opportunistic about every time we come in touch with a client or a potential client. And I think that is it for me. So I look forward to learning from everybody. Thank you.
Thank you, Sarah. Thank you so much for providing some of that really helpful context and some really important points around some takeaways, some of those sort of cross-context learning. And I think we'll probably hear a bunch of these themes brought back up as we look at 3 different country case examples next. So thank you for setting the stage, and let's move on to our next panelist, Tolbert Nyanswa. He is a public health leader, a faculty member, a senior research associate at the Johns Hopkins Bloomberg School of Public Health, and he's also a DRPH candidate, getting ready to complete his doctoral dissertation soon. So congratulations on that, Tolbert, as well. Tolbert's been working in public health emergency preparedness and response for a number of years, including working in Ebola, Lassa fever, Zika, meningitis, and currently COVID-19. He has worked in his home country of Liberia as well as internationally, and really was pivotal in Liberia's successful response to the 2014 to 2016 Ebola crisis. He worked in a number of different roles, including serving as the Assistant Minister for Disease Prevention and as the Deputy Minister of Health for Disease Surveillance and Epidemic Control for the Ministry of Health in Liberia. He also established Liberia's first National Public Health Institute after the Ebola crisis and became its first Director General and CEO. So welcome to you, Tolbert. Thank you so much for being with us, and over to you.
Thank you, Margaret. How are you? And fellow panelists and participants, thank you, Sarah, for great presentation. I'm excited to be here to share some real-time experiences from the front line, like Sarah mentioned, to put some real concrete examples of how you build a primary healthcare system that can withstand shock. Next slide, please. So in the context of low middle income countries, next slide, we want to look at what are the challenges, what cut across really common challenges in low middle income countries. We all know that, and when I was incident manager of the Ebola response in West Africa between 2014 and 2016. Some of the issues was, first, how do you detect a case when it happens, especially when it's a novel pathogen? Setting up an incident management system can be a problem. Significant at-risk population in where we live, especially in Sub-Saharan Africa. Multi-generational household, people are finding difficulties and the risks that go with that. Limited healthcare capacity, and this is where community health workers and community health workforce is so important when you cannot get the services that people are supposed to have. And during COVID-19, one of the issues that we were dealing with was quarantining the population. And one of the things, after having several interviews with the BBC, US media, global media, one of the things where it would be very difficult for places like Africa to knock down their whole population because of the consequences of people, subsistence farming and how to get food and all of that, some of the difficulties that low middle income countries face. Next slide, please. And so during the Ebola crisis, who really paid the price? We saw that. I try to give you a background so that at the end of this presentation, you will realize that you will see how critical it is to build primary healthcare system that can withstand shock. And so the Ebola epidemic in West Africa was one of the dramatic public health. Before COVID-19, Ebola was the one that the entire world was dealing with, a post-existential threat to 3 countries in West Africa. For those of you I know, you all are interested in epidemics and pandemic response. You may have heard or read a lot of articles about Ebola response. I was in the middle of that and leading it as incident manager in the heart of the outbreak. And international public health was threatened because of that crisis. And we saw that before WHO declared the public health emergency of international concern over in March of 2016, the region, 11,000 people died and about 28,000 persons, got affected in the 3 most affected countries of Guinea, Liberia, and Sierra Leone. Next slide. So what did we do? And this is why, next slide, please. This is why it is important for of moving toward resilient healthcare system, primary healthcare system, the core of our conversation today. After Ebola, we re-engineered ourselves and said, look, I think there's something lacking in our health plan, in our health policy in the country. So we went to work and said, look, we have to build a system with services provided, even when there is health threats that can withstand those threats, assuring universal healthcare. So 3 pillars, 3 things we think about. How can we make emergency risk management a core issue, the appropriate enabling environment to respond to outbreak and access to quality health services? So resilient healthcare system, meaning you demand-driven healthcare workers, giving them skills like field epidemiology program, engineering healthcare facility with infection prevention and control services, emergency preparedness and response services, and providing effective health financing. My colleague Sarah mentioned some of those things, so I don't want to take long of it, of how you build resiliency. Next slide. And at the core of that is healthcare workers and community healthcare workers. First responders are the backbone of primary healthcare. Next slide, please. Are the backbone of primary healthcare. We noted that preventable deaths, especially among children, is 7.6 million children under 5 dying each year. And neonatal death is one of the major causes with pneumonia, malaria, and diarrhea, and all of that. So what we did was, as part of the surveillance system, neonatal death and maternal death in Liberia were one of those that we include on our priority disease list. And as we go on in the presentation, you will see that. So community health extension workers, you can talk about Ethiopia, you can talk about Pakistan, Nepal, and all of these things. This slide meant to tell you that, you know, we still face, Africa and Asia still face almost 4 million shortage of workers across that, and to tell you how important to deal with some of these health issues that I mentioned, acutely children under 5, that healthcare workers and first responders are backbone of primary healthcare. Next slide, please. So when after the Ebola crisis, there were a lot of theories and a lot of theories of what really ended the outbreak in Liberia. There were people who said the deployment of the United Nations workers to Liberia, the first establishment of a UN health keeping troop in Liberia was the one that ended the outbreak. There were others that said that because the US military were deployed to build Ebola treatment units. But we went to work, and Cash and R did an impact and what really stopped the Ebola outbreak. I was appointed as incident manager in the middle of the outbreak. If you see August, then when we reorganized the incident management system and they got active with community engagement with safe barriers in July and all of that. So if you see from April, if you see the reproductive numbers, and then you see the number of months and the interventions that took place during the outbreak, you will see what really ended the outbreak with some of these interventions that are on the slide. The next slide, please. So when you put that into writing, and you will see that community engagement was key. We're talking about primary healthcare. You cannot leave the community back. Please, next slide. And behavior change, safe barriers, hand hygiene, and all of these things were applicable to the COVID-19 response that we talk about, barriers and all of that. My next slide will be on, if you do not engage the community, move on, please. If you do not engage the community, what you experience. In one of the slum community in Liberia, called West Point, we saw that there was, agitation between the military and the community people because we didn't engage the community. There was rioting. Even the military shot at somebody that died and lost their life because of some of these things. So when you engage the community, then community health workers and intervention can do a great job in that. Next slide. So we set up the incident management system. And I know during this outbreak in the Ebola EOCs, which is Emergency Operations Centers, during COVID-19, those are some of the lessons. Immediately, countries were able to set up incident management system to respond to COVID-19. Next slide. The structure of an incident management system, we had the Minister of Health, the incident manager, the president was involved, and some of the thematic areas that was in the incident management system. You can talk about epidemic control, contact tracing, laboratory, social mobilization, case managers. These are people that we work with. So the leadership was from bottom top down, approach distributed leadership that end the outbreak. Next slide, please. So at the community level, this is why primary healthcare is critical. You cannot, build a resilient health system without telling the community people on how to detect diseases. So one of the things that we did was we developed job aids at the community level. If you talk about polio eradication, acute flaccid paralysis, which is one of the priority disease, you have job aids to show how people can detect that. Acute watery diarrhea. You can talk about human exposures to rabies. You can talk about measles. So all of these diseases and meningitis that we deal with, we created job aids for community people to identify. Next slide, please. Now, my question here is, emerging infectious diseases preparedness using primary care, but is this possible? After the Ebola crisis, we thought that there was organizations that emerged. One of those is the Africa CDC. One of those is the Global Emerging Pathogen Treatment Consortium. And from their consortium point of view, using One Health approach is one of the critical ones where people in the human health sector, the animal sector can come together. And so emerging infectious diseases, can we predict them? Can we predict the rates? Can we develop capacity to detect them before they become pandemic? Can we detect outbreaks early? Can we prevent them? It is possible, and I will tell you how it is possible. Next slide, please. It is possible of what we saw that prepared Liberia for COVID-19 response. Effective response to the COVID-19, West African leaders scrambled when there was Ebola. For COVID-19, the Africa CDC went in through there, the field epidemiology program that was built in Liberia. Dr. Mikey talked about establishing the Public Health Institute in Liberia was one of the great things that we did. Incident management system, the West African Health Organization, they all came together and aggressively approached the contact tracing, education, engagement of the community. All of those are lessons that help with COVID-19 in the country. Next slide. The Public Health Institute was a mandate, umbrella organization. Next slide, please. That prevention and control when EOCs were all set up. As a consequence of that, we've seen low case level in Liberia between March to December. They reported 6,000, about 7,000 cases with 248 deaths in 21 months, as compared to Ebola, where 11,000 cases were reported in the country with 4,000 deaths. Altogether, apply enhanced the COVID-19 response. So my takeaway message on the next slide, please move ahead, is that the recent COVID-19 and Ebola taught us that investing in primary healthcare preparedness and tackling infectious disease outbreaks caused by emerging pathogens and public health emergency, building health system capacity and resilience, overriding can stop the next pandemic. That's how we need to stop the next pandemic. Thank you very much for your time.
Thank you very much, Tolbert, for bringing in some of those learnings that we have from looking back at Ebola, and also some of the practical processes and strategies that were used in Liberia and beyond. So thank you, and looking forward to picking up on a number of the themes that you raised as well when we get to the discussion. So let's move on to our third speaker. Dr. Rehana Ibrahim is a management consultant and medical professional in Nigeria. She has experience in health innovation and strategy, program design, implementation, and monitoring, as well as organizational strengthening and capacity building. She's worked at the Selina Center for International Development and Research for over 5 years. She was a program manager for a significant portion of her time at SIDAR in the northern Nigerian states for their routine immunization system strengthening program, and worked on healthcare delivery for 6 northern states to ensure vaccine delivery and essential services to women and children. She's currently the associate principal at SIDAR, where she coordinates multiple teams to provide technical and management support to governments and donors in the design and implementation of sustainable innovative development interventions. So welcome to you, Rehana. Thank you very, very much for joining us today, and looking forward to your insights from Nigeria and beyond.
Thank you very much, Dr. Makey. Please confirm that you can see my screen.
Yes.
Okay. I'm just having some technical. Great. Yes, I'm back now. Thank you. So for today, I just want to quickly share some experiences and lessons from our work in Nigeria, specifically highlighting some of the work that we've done in primary healthcare, and how we've had to adjust with the advent of COVID and all of the adjustments the country had to make. And now, as we're integrating with vaccines, routine vaccines and COVID vaccines, what we're learning, and how we're thinking about rebuilding more resilient systems that can withstand the shock of that overarching pandemic or peri-pandemic contexts. Some reason my slides aren't moving as fast as I would like, so if you just can give me a second to fix that. One second. Yeah. So I will start with a brief background of the COVID response timeline in Nigeria. Nigeria recorded its first case in March of 2020, or I mean late February 2020, but then declared an emergency in March 2020. And in that first acute phase, the focus was on active case finding and deployment of rapid response teams and, immediate response to the acute pandemic or disease outbreak. By Q2 to Q3 2020, the focus was really on intensifying surveillance and case finding, strengthen infection prevention and control, scaling up testing capacity, because that was the challenge in the acute phase. And of course, a lot of programmatic adjustments in the context of lockdowns that were affected in the country. Programmatic adjustments were both financial and strategic. All of the states had to cut down their budgets, and that ultimately affected the program. And of course, with the lockdowns, the strategy for program management and service delivery had to be adjusted as well. And then by Q4, with global advancements in knowledge as well as vaccine advancements and complementary easing of lockdowns, it was time for us to do catch-up campaigns. So we did integrated medical outreach programs, periodic intensification of routine immunization strategies, and all kinds of catch-up campaigns to try to recover from the impact that the pandemic had on service uptake. And of course, the planning and certification for vaccinations also commenced in this phase. By 2021, in March, we were able to commence vaccination, starting with the priority groups of essential health workers, strategic leaders, and people with comorbidities. So a lot of people that were at risk were prioritized first. And by 2022, or by the later part of 2021, we had expanded the response or the vaccination program to get to the general population with mass vaccination campaigns rolled out and focus on integrating routine vaccination, primary healthcare service delivery with COVID vaccination. And now more recently, we're moving vaccination access as well to private health facilities for people to also obtain their vaccines from these service providers. Looking at the, yeah, just some lag in the slide movement there. Looking at the lag that we had in the phases of the program, I just wanted to quickly highlight some of the work that I've been privileged to participate in the response, just to paint a picture of what experiences I'll be sharing and where they come from. So in the initial case control phase, there were things at the national and regional level that were done. And at the national level, it included some management capacity building that was really rapid for the very young agency, that is the Nigeria Center for Disease Control. We also did some scale up of diagnostic capacity working with the NCDC. We're also able to design some catch-up PHC campaign strategies, taking vaccines and other family planning, maternal health services to the communities. And of course, crafting COVID messaging. And of course, helping to think through what sustainable financing might look like in the context of COVID in the States. At the regional level, we did things from doing impact assessments from COVID, trying to define strategies for service continuity, even during the lockdowns, helping with PPE logistics, computations, leveraging existing supply chain systems, etc. By the vaccination phase, however, we were able to support designing the mass vaccination strategy through our participation in the COVID-19 technical working group at national level, working on the vaccine delivery plan, the demand generation strategies, as well as, helping with screening and deployment of vaccination teams. And over time, we've continued to provide technical advisory to the state coordinating bodies to continually strengthen their vaccination delivery. So that's for some context on Nigeria's journey on the COVID response. To go further, I want to discuss why PHC systems are important. First, by painting a picture, building on what Sarah had discussed around the PHC building blocks that we know. We know that primary healthcare spans quite a number of service areas targeted at quality service delivery. But to be able to do that, most efforts are targeted around advocacy, system strengthening, and capacity building towards the specific, would I say, themes or building blocks of PHC, sustainable financing and financial management, efficient supply chains, adequate and skilled health workforce, robust M&E systems, standard health infrastructure, community engagement and social mobilization, and of course, support supervision. These are kind of like all of the pillars. And of course, all of that is anchored by a strong coordination or leadership and governance structure that will ultimately result in the outcomes that we want to see. And before the pandemic, Nigeria had been making steady progress across the key intervention areas, as you can see to the right, which was ultimately leading us to reducing the mortality rates in children and in women. However, with the pandemic, there was a shock to the system, and of course that led to a number of consequences. Looking at it from a poverty index, we could see how 2020 worsened what we saw there, and we haven't quite gotten to the optimal level that the globe is trying to get to for 2022. We also see that the world vaccination rate reduced significantly after being on a positive trajectory hitherto 2020. But then, just like Sarah mentioned, Africa was even more hit by the aftershocks of the pandemic. We see that Penta-3 vaccination coverage dropped, which is an indicator of, how well our children are prevented from getting VPDs. And of course, the UHC index also continued to get worse in 2020. At the local level, talking about local context, we saw how devastating it could be in rural communities, especially where trust in the health system was already thin. A health worker that we interacted with in one of my implementing states, described just how much damage it caused when, there were rumors in the facility and patients that were on admission bolted from the place. And there was a lot of chaos, a lot of distrust in the health system, a lot of children that weren't vaccinated or didn't complete the schedule, and many mothers who missed that opportunity to get better child spacing services, etc. And that trust is something that we will still continue to try to gain back in the next decade, because it takes a lot of time to be able to garner that trust for the communities to, believe in the health system enough to continue to take up services. We did some impact assessment, like I mentioned earlier, and there were three key things. There were disruptions to program management. All of the coordination meetings, the planning, the work plan implementation was really poor in that first half of 2020. There was reduced funding, of course, and a lot of activities could not be implemented. Everyone had to reprioritize resources towards COVID. There were also interruptions to service delivery, like I had mentioned. Some hospitals were shut down. Some health workers didn't show up, of course, because they were also concerned for their own safety and didn't feel adequately protected. And of course, there was that waning demand from the community side. Now, looking at it a bit more closely, I'm using some examples from our work here to show how devastating this was, but then also to look at what other consequences or what other things COVID taught us or COVID revealed about our system. So we had been building systems for decades. Things were looking up. We had started to see some results, but we found some patterns that suggested that some of our interventions or program strategies were also faulty or built on some false assumptions. So for example, one of the ways that we work with governments to ensure that there's funds for immunization and primary health care is through memorandum of understanding and joint or counterpart funding. We were able to know that a lot of these costs were in the budgets for the year, but earmarking or ring fencing funds in the budget was not enough. Most of our states were not able to pay those monies that year, and only one state was able to pay. Some of them didn't even pay at all. And of course, that taught us that we needed to do more to guarantee availability of funds in a sustainable manner for primary healthcare going forward. Another thing that we saw were the declines in session conduct and complete shutdown. And supervision was still going on. That is the traditional supervision where supervisors go to the facilities, but that didn't necessarily translate to improved service uptake. And of course, that disconnect calls to mind the need for us to think of more novel ways to address supervision and mentoring at the facility to guarantee quality. It might not be as efficient to just send supervisors to the facility to conduct these services. So it's important for us to think through that. We also learned that the core demand creation strategy was not enough to improve community trust or get the communities to continue accessing services. The pandemic was, or the fear of the pandemic trumped all of the mobilization that we had done over the years, all of the caregiver education. Clients accessing services reduced, even though the core strategy continued to go on around that time. And so a more holistic strategy to improve community participation and share knowledge was obviously evident. And of course, for vaccine stock performance, we learned that vaccine accountability was questionable. We saw that stock out rates did not improve. We expected that it would improve, understanding that surface uptake was reduced. You would expect to see more vaccine stock, but then we found that that didn't necessarily change, and that kind of got us to challenge ourselves to say, what else do we need to do differently to be able to actually build systems that work and also continue to strengthen accountability in the system. But I mean, understanding that that system building was something we needed to do further down the line, we still needed to continue to respond. And part of that involved in the initial phase, establishing relevant coordination structures. This was successful because it was easy to build on the EOC structures that we already had from polio. Nigeria had robust investments in polio and routine immunization, and a lot of those investments were very useful in coordinating the COVID response. And of course, the state task forces on immunization that had high-level political leaders was also leveraged or expanded to cover COVID-related topics. Of course, the response plan was easy and fast to develop because we already had strengthened management and coordination capacity. The work tools were available, so it was easier to plan while the response was going on. For resource mobilization, there were different things. There were pooled funding innovations that were leveraged through the Coalition for COVID funding that was established in the country. Funds were also channeled from savings from primary healthcare investments before, and that kind of helped to tide over some of the initial shock of the pandemic. And of course, the field teams that were deployed were also people who had been working in the polio and immunization program for a bit. The reference labs were also leveraged using PCR and GeneXpert machines to do the testing in the early phases and scale up capacity. There was also using the established channels of the traditional leaders that had been, extensively developed through polio and immunization to continue to push messages down. And now with adaptation, there have been different ways that the COVID vaccination or, just thinking about synergies across board, two-way synergies. So program coordination has been made more flexible. Meetings were pushed to virtual platforms, AOPs were reviewed, risk communication was done, and instead of messaging only for COVID, figuring out ways to message for COVID and other vaccinations as well. Maintaining essential services, we were able to continue to do that to boost service uptake by intensifying what currently existed and leveraging all of the COVID resources to also strengthen PHC. And of course, continuous intensification interventions that were put in place. For programs like HIV, which I also lead in Solina, we were able to use different service delivery models to ensure that patients still got their antiretroviral therapy. And of course, all of those innovations were very useful and got us thinking some more about, how do we consistently leverage systems and build a more integrated system for primary healthcare. This is just a quick look at the vaccine supply chain system that we had built. It was one of the most resilient, even during lockdowns, even when everything was, really, really bad. Vaccines were still delivered to the service delivery points because that system had been designed to really work. But more importantly, states were able to leverage the vaccine delivery system to send PPEs and other COVID supplies to the facilities, and also use the data management system to pull back data on what was going on with infection prevention and control in the facilities. And ultimately that helped to, provide a system that could catalyze the infection prevention and control that we wanted to see. The current strategy that Nigeria is implementing is called SCALES, which is an acronym for service delivery, communications, accountability, logistics, electronic management of records, and supervision. The way that integration is currently going on is that states have been tasked to have one all-inclusive annual operational plan and to use existing structures to continue to do this. So one team, one plan, and one M&E. Service delivery is integrated by using the traditional RIU approach, but then also adding on electronic registration for COVID, with plans to scale that to primary healthcare over time. All routine vaccination points now provide COVID vaccines and vice versa. And then, of course, for the demand, like I said, messaging is done in a harmonized manner. Rumor logs were established to get rumors that were going around COVID, but now also including other services such that the response can be robust. For the cold chain, of course, the country leveraged all of the cold chain equipment for routine vaccinations to store COVID vaccines, and also in the states that already have that architecture, pushing vaccines to the last mile was easier, leveraging the delivery teams. And of course, like I said, the data management is something that has commenced to expand this to also have an electronic registry for children's vaccinations. And of course, for surveillance, the immunization and polio AEFI systems were used to also track COVID AEFIs, and then also bringing in an application that allows you to record some of the after effects of the vaccine. Looking at some of the results, we see that Nigeria has made some progress or has been making progress since the commencement of the vaccination. If you look at the charts, this really just describes the daily vaccinations and not the cumulative. But then on the top, you can see what the total target of Nigeria is. It's quite a populous country, and we're currently at 38.5% of first dose vaccinations, and roughly around 27-28% for fully vaccinated people. Part of the challenges we have is because we're using 2-dose regimens, there's things around dropouts and missing people between doses, and that's something that the country is actively working on. But then, of course, we have some cohorts of people who have already gotten their booster shots, and that continues. But when we look at the value add, there are over 1 million children who would have otherwise been missed that have been vaccinated through COVID, during COVID vaccination campaigns. And of course, that contributes to the overall Penta-3 vaccination uptake in the country. Looking at some of the challenges overall, in addition to what I had described earlier, some things around the vaccine hesitancy is a big challenge. That has always been a challenge in Nigeria, but now even more so, even in the southern parts that didn't used to have this issue. Of course, there's issues around the target group. Now it's adults and it's not children, so there's different dynamics around demand. Resource limitations, of course, it's a very cost-intensive program to deliver COVID vaccines within a very short time to over 100 to over 100 million people. There's a high burden on health workers because it's still the same program managers, still the same service providers delivering COVID vaccines. And of course, some capacity gaps around managing the new technology around immunization registry. And Nigeria has some insecurity and terrain issues that limit access to some communities. And so we have some equity considerations that we continue to factor into the strategy. Overall, the lessons have been a lot, but we know that one of the key things is that data has to be available, data has to be accurate, and we need to build systems that help us have that data to juxtapose against different trends and also be able to predict and manage pandemics when they arise. Systemic integration is very crucial. Part of the work that we've been doing is making sure that, we are not talking about vaccination alone. We're not talking about deliveries alone. We're not talking about antenatal care alone, that we're going together instead of verticalizing. COVID has stressed the need for that. The health workforce is also very crucial, and we need to be able to upskill the existing human resources, but then also expand that to be able to meet a very large population. And of course, we need, like Dr. Tolbert said, we need investments that are channeled towards pandemic response, and we need to ring fence funds for that so that we can be prepared whenever that comes and not have it be after the fact. Earlier engagement with communities is also very important. It needs to be context specific as well, because what works in Northern Nigeria doesn't work in Southern Nigeria. And I've also found in some other countries that I support, like in Guinea-Bissau, the communication and the messaging itself has to be completely different. Trying to understand from the root causes, what is it that's keeping people from taking vaccines, and then crafting messages to target them. And of course, beyond the messages, the messenger is also very important. And that's something that should be done, because hesitancy that we have now ultimately translates to hesitancy in future pandemic responses. And lastly is the flexibility. We need to build PhD programs that are flexible, that are agile, and that allow us to change things as we go. Using the data that we harvest, we need to continually know that we can't have theories of change that are fixed. We need to be able to change them often as we learn new lessons. And of course, just like Sarah said, it's very important to have the power of the collective in play. Cross-sectoral collaboration is the only way to go, and to go fast. Thank you very much, everyone. I will hand back to Dr. Maykay now.
Excellent. Thank you very much, Dr. Ibrahima. That was a lot of great information there. A lot of good insights into some of the potential sort of setbacks and challenges from COVID, but then also some of the strategies and what we've learned and ways forward. So we're a little bit behind time and really excited for our final speaker. So we're moving from West Africa now back to East Africa, back to Ethiopia. So it's a great pleasure to welcome back Dr. Mebrahtu Masebo, who has been part of our team in different ways over the evolution of this course. So thank you so much for joining us, Dr. Mebrahtu. He brings more than 15 years of health systems experience and is currently a senior advisor to the Minister of Health and the coordinator of the COVID-19 National Response Task Force in Ethiopia. He has worked previously in facility readiness and case management, and also started his career from grassroots primary healthcare unit experience, and then has worked his way up through the system and has held a range of different roles, including serving as a hospital CEO of one of the national leading hospitals in Ethiopia, and more recently has become a national policy advisor. So his focus is on excelling in leadership skills and being able to guide health sectors toward greater improvement of emergency management and towards universal health coverage. So welcome to you, Dr. Mebrahtu, and over to you.
Thank you. Thank you so much for the fun introductions. Even though it's the last presentation, I think this will be the very good and the best presentation I expect. And I'm very much humbled that we have a good presentation from my friends. And let's give me a few seconds to share my slides.
Dr. Mebrahtu, we don't hear you at the moment. Oh, there we go.
So sorry, so it's
That's fine. Looks good.
Nice. So thank you so much. And I just focus on the impact of COVID on primary health care, especially in the essential service, and also the overall social and economic impacts. And also I will focus on the lessons we learned from this response, the challenges we are seeing in the health system, and also how to make it resilient. And I'm here to learn more from the team. So with this, like, as you know, Ethiopia is one of the biggest country in Africa, second to Nigeria, as my friend told me. So if you have these two countries experience on top of Liberia, we had earlier, and also African global context, I think you will have at least 1/3 of African lessons, as the number indicates. So we are around 120 million in the population, and the majority of Ethiopians are living in the rural, and still there are significant number of proportions are affected by poverty, and also the economical growth is also somehow affected by the COVID. So there is currently high inflation, unemployment, conflict, climate change are the major challenge the country faces now. So we have governance in the federal level and then the regional level. So, and also there is a health sector, as you know, built from the grassroots to as a primary healthcare unit to the national level. So we have a tier system in the health system. So we have estimated to 450 hospitals and more than 3,700 health centers, and also we have more than 80,000 health posts. And in the COVID response, the very important thing is national and reference regional laboratories, and also the national and the subnational hubs for delivery of the response tools. So we have also health facilities providing immunization, which are greater than 21,000. As we are seeing in the other case, the milestone for us was December 2029, where cluster of pneumonia reported in China. Then also WHO declared the public health emergency at the 30th of January. Then coincidentally, we activated 3 days before WHO declared pandemic, our emergency operating center in EPHI. So Ethiopia also had started laboratory testing by February in country. And also by March, we detected the first case. And also by April 2020, we declared the first days and also state of emergency in our response. So there is also a vaccination which is launched by April 2021, exactly 1 year after we registered this in country. So this is the milestones and our major objectives and priorities for the response were mainly concentrated on minimizing health, social, and the political impacts of COVID-19 pandemic. So our major framework for the response were mainly focused in this area, suppressing the transmission and to reduce exposure, also to protect the vulnerable groups, and also to reduce morbidity and the mortality. So we also had always an eye on strengthening core health system functions. That's the major area today I want to focus. So it's including resource mobilization, it includes to work toward this resilient health system from the start of the pandemic. And we are also in thinking in the mind integration of COVID-19 services with routine health services. This is just the strategy from the start. So we are always working towards to these goals. With this, we already vaccinated about more than 5 million. We had already tested more than 5 million population, and also positivity, average positivity as of August 50 was around 10%, and our case fatality was 1.5 from the cases. And we had also passed 5 waves. The most biggest wave was Omicron, which came with 35.4% positivity. On vaccination, I think we had already received about 67 million doses, and about 58 million were distributed. And also totally we are in state about 51.9 million doses. And also about 43 million were received at least 1 dose. These are the population. So, and also we 36.6 million population, or 34% of total population from 120 million are already had full vaccination. So we are not on the first presentation in the first category, and we are not in the last category. So we are in the middle and in between 30 and 40%. So we are aiming to reach to 70% of those targeted population, which currently we are in 67%. And also we are aiming to reach to 70% of the whole of population by 2023 as a plan. So we already monitors the distribution throughout the region, and also the gender and the age balance of the vaccination. So we are always at the strategic level looking to the equity between the gender and the regions also. And also we are reached that 52-48% at last. In our response, the major lessons we had: early activation of Public Health Emergency Operating Center was a great achievement. Then restriction of gatherings and the closure of the major gatherings, including schools, and for preparation, we are already strengthening our stringent criteria with statement of the emergency law that the parliament passed. Also, risk communication and the community engagement is a big issue for NPI implementation. Multi-sectoral response, even though it was somehow higher and somehow goes down, it is the milestone. And in the surveillance, the major thing we had at the first was house-to-house visits, contact tracing, mandatory quarantine, and the border closure. Then the others followed us as the pandemic epidemiology goes. So our response on the challenge on health system specifically, we're mainly focused on governance, finance, health system, the research and the development, which really we lacked with resiliency when we start this pandemic. And information, coordination, and the service delivery were so much affected as usual. So learning from COVID, global health landscape should be changed, we believe. So we need to recalibrate the losses we had with sustainable development agenda. So we need to backtrack those SDG agendas, and also post-COVID pandemic treaty, which we are working together with WHO to shape the future of the response for next pandemic. When we come to our coordination, so the major thing worked in multi-sectoral response was community leadership, religious leaders engagement, and also CSOs and the private engagement, especially the local users at the grassroots level movement were very much a lesson we learned in the response. In the resource mobilization, as I told you, this is somehow the country under development. So we were struggling to mobilize adequate finances, but the biggest achievement we had at the peak of the pandemic was like mobilizing multilateral and bilateral government partners, and also private CSOs and individuals, private citizens also contributed a lot. The government contribution was about 42% from all of the response. So others are covered by the private and the bilateral donation we have. We had also $500 million USD worth commodity supported by communities and manufacturing hubs, and everyone chipped on the response. With this, we expanded the quarantine facility about 15,000. Added that this very milestone we had, and without that, like it will almost take all of our hospital and the health center facilities. And also in the treatment, we reached about 22,000 treatment base at the facility. So this can be in average in Ethiopian, it's more than 50, 60 hospitals, big hospitals built in very short period as ad hoc. And also we had strengths in ICU, mechanical ventilators, oxygen capacity, PPEs, mentorship and the training to shift the critical care capacity to the lower level. So more than 62,000 health care workers were participated, and also as all of Ethiopian health workforce, which includes 270,000 health workforce engaged directly or indirectly. So when we say directly, they are working in the COVID, and indirectly we say they are restoring and keeping the health systems to make it resilient. We already hired 6,300 contractual staffs from unemployed pool. And we try to have life insurance for the deceased one. And we had also had hazard top up for people working on the COVID center and the COVID response. So the major integration we had witnessed with the primary health care is working with alignment with community level interventions to reach to house to house and outreach activities for vaccination, and integrating with other public health emergency surveillance systems as we integrate COVID with IDSR system. So strengthening IPC measures in health facilities and in the community, which was a milestone for suppressing the community level transmission. So gradual repositioning of shifting resources to the essential services. So always we had two eyes on one in essential service and the other in the pandemic. So keeping this balance was a greatest lesson we learned from the pandemic. Even though with these achievements, we can't deny that there are, the first impact was the death. We officially recorded about 8,000, then unofficial estimate from WHO puts us about 76,000 deaths in year 2020 only. And also, if we add these 3 years, that can be more than 100,000. Compromised essential services, including postponed surgeries, waiting time, TB, malaria, HIV, which we reached with a great struggle for decades of contribution from different actors, then it was really hampered by this pandemic. Economically, the reduced income, job loss, inflation, and everything associated with economic struggle currently we have at the country level can be associated with COVID. In the schools, so the lost years and gender-based violence, early marriage, and banning of gathering for religious and social events also affected the community level. So in the politically postponement of general election and the consequence came back, or major milestone we registered as impact. Also, widespread transmission, we were struggling really to keep the calm that I really discussed earlier, to put the essential health service accessible to the community. So it was a very much struggling time for us. The government has invested heavily in COVID with mobilizing resources, and this physical pressure, managing the debt we have, and also investment in emergency preparedness increased, but we need not to neglect the achievement and run away from those built capacity going forward. So in the capacity, we need to focus more people than ever need emergency assistance. So we need to mix the outbreak management with humanitarian emergency and health security. So as at the national level, strategically, we see humanitarian emergency, health security, outbreaks together. So not to lose in one or in another. So there is also consensus building for technical work. And we need to have decision at the compartment levels, at the federal, at the regional, and the local offices. Technology, as mentioned earlier, were a big innovation we had seen in the COVID era, but this technology should be matured to make Africa a manufacturing hub. Policy levels, so we need to reform decision-making and the priorities as per the pandemic going forward. So we reinforced international health regulation, and we try to mobilize local capacities as much as we can in country, because we were alone when the COVID hit the whole of the world. When all 6 building blocks were really hampered, but we need to, we try to focus in the leadership to have coordinate the whole of the government and whole of society response. But this leadership had always had a weakness, but some strengths saved us from the catastrophe. Some are already modeled that Africa will pass. So immediate priority will be early warning and the response systems for all health threats, logistics, epidemiology, and the building the capacity of the health workforce for future pandemic. In R&D, so we need to focus as Africa in new technologies, mostly vaccine, drugs, diagnostics, and operation. Also, we need to target the roadmaps which will have a cluster-based manufacturing than individual country by its own. So we can have East Africa cluster, we can have Central Africa cluster, West, South, and anywhere like which can be shared as an Africa. Because at the start of the pandemic, at the start of the vaccine, Africa, 99% of the vaccines came from outside Africa. So we can't say we have a tool for future pandemic without this local manufacturing. So domestic manufacturing in country and in continent is the biggest lesson, and we need to collaborate as African scholars going forward. And my point for you, my participants, are really we need to be hand to hand to reach to the global level that Africa we wish to have. So these are the areas which I mentioned for future research and learning and essential service and building resilience in the public by quickly, preemptively debunking the misinformation that we had seen and earned. So post-pandemic, we need to institute national operational plans in the multi-sectoral collaboration. Efforts to protect safety, health, and the well-being of health workers should come at the first. Thank you so much. This is few of my lessons. I'm here to answer any question you have. Thank you so much.
Thank you so much, Dr. Mebrahtu. I think we have heard 4 fantastic presentations. We've covered a lot of ground. Thank you so much to all of the presenters for bringing your experiences, your perspectives, a whole lot of evidence and examples and strategies and everything to this discussion. I think it's been a whirlwind and also I think really inspiring and insightful to be able to hear from leaders and people who are really on the front lines of this work from across the region. So thank you to all of you. Given the time that we have just a few minutes left, I'm going to briefly summarize a couple of the cross-cutting themes that we've heard. A lot of questions have been answered in the Q&A section. So if you put a question there, there may very well be an answer from one of the panelists there, and some of the panelists may continue to write some responses there in the next few minutes. And then we're just going to have one closing question for the whole panel, kind of around the way forward and some takeaways of what we have learned and some of the successes in the region, as well as how we can be better prepared for the next public health emergency as it comes along. So we've heard a lot about the health workforce, both how important the primary healthcare workforce has been, some of the challenges with ongoing shortages of the workforce, with things like vaccine hesitancy, stigma, lack of access to appropriate supplies, and many other things. But clearly the workforce has been incredibly essential and also is facing challenges across the region that require ongoing collaboration and work. Interesting discussion around production of vaccines in the region, some different perspectives. Thank you for bringing that up, Sarah. A lot around innovations and different ways that a lot of different stakeholders have been brought together to provide services, to mobilize resources, and just to collaborate together for the response. So a lot around that, and then also a lot around the importance of financing, some of the challenges around financing, different ways that countries and the region have mobilized resources, and then also looking at some of the sort of larger collaborations, strengthening institutions both at national level as well as at regional level in order to be able to mobilize, coordinate, and continue to strengthen strategies, evidence, and be able to work in the future on future public health emergencies. So we've covered so much more than that, but those are a few of the kind of takeaways just from being able to listen to all of the wonderful speakers. So my last question to the panel, which I want to just pose in the order that everyone spoke, is, in your perspective, maybe what are one or two specific ways that the country where you work and/or Africa are better prepared for the next pandemic, given our experiences? And maybe a suggestion of one or two things that you think we need to continue to work on together. So I can pass to you, Sarah, if you want to just take 1 or 2 minutes. Would love to hear your reflections, and then we'll go around the rest of the panel.
Great. Thank you, Micah. And thanks so much to the presenters. I think I've learned a lot just from listening to my colleagues. It's been a very useful exercise. And thank you, Micah, for summarizing the cross-cutting themes, because I agree. I think those are the most pertinent ones. I think in terms of some of the concrete things that I've seen and should be carried forward after the COVID pandemic, I'm going to just go to the one, for me, the one that I feel strongly about is local production of vaccines and therapeutics in the country, because several countries have already been putting up plants to develop vaccines and I think there's a lot of support that's coming in from different places, from WHO, from private pharmaceutical companies outside of the region, and even from governments. So a specific example is Ghana just this year committed about $60 million to support local production. And the reason why local production is very critical, this issue of hesitancy, I think, is largely because of people looking at a product coming from the West. So how do you convince someone that this is something good when we've already been dealing with hesitancy with all other vaccines? So I think having local production to create even better ownership for products, because once you see the vaccine is being produced, for example, in Ethiopia or in Ghana or in Kenya, it's a product that you know where it's come from. And so it addresses some of the hesitancy. Hesitancy will always be there. But I think the issue is going towards looking at local production. That way also it addresses the issue of availability. That way we're not always going to be on the end of the line to receive the vaccines. And then of course, there's other issues that, as someone said in the recent regional committee meeting, is we know our problems and we know the solutions. So the issue is, how do we connect those dots? How do we come to, we have been doing a lot of research about hesitancy, some social listening. We know what it's going to take. I think the issue is being a bit better coordinated and collaborating a little bit better to look at where we have opportunities that we've missed. So I think we need to sit and regroup, at least as program managers, as decision makers, and see where is it we're missing something here. Because why should, for example, a country like Cuba has had the best coverage so far globally? They've had the best coverage. Why is that? Is it because they have more health workers? Is it because they're more motivated? I don't know. But I think we need to ask these questions, and maybe also documenting why these top 3 countries, Rwanda, Mauritius, and Seychelles, why do they have 70% coverage and other countries don't even have 10%? I know a lot of it might be logistical issues that are still bigger and outside of vaccines, like, like particularly Sudan and South Sudan, or even DRC. But I think it's been a moment for us to see what we're capable of. But I go back to, we know our problems, we know the solutions. So what's it going to take? Thank you.
Thank you, Sarah, very much. Over to you, Tolbert. How is Africa and Liberia better prepared now? And where are the opportunities for further progress as we go forward?
So thank you. I'm the before, during, and after person. If you put in context where the African continent was when we had the huge and unprecedented Ebola outbreak, and look at the preparedness and response capacity from the level bottom top to the Africa CDC top level, and coming down to countries and regional level institutions and country level capacity that have been built over the years. I believe that, strengthening primary healthcare, which is core to the discussion today, is the way to go, where we can prevent diseases before they start. Even if they start, we can test them very quickly at the point of where the disease is. And, stand up incident management system, EOCs, emergency operations centers, train healthcare workers in emergency preparedness. Some of the questions that some of my colleagues raised here during the Q&A that I was able to answer some of them is, why were the cases in Africa and high income countries were highly hit as compared to countries like Africa with the COVID-19 pandemic? And you can really see that research point to the fact that age is a contributing factor, and underlying conditions like diabetes, pre-existing condition, heart disease, cardiovascular diseases, and all of these things. And the population of high-income countries, if you look at between 20 to 30% of people fall in the age category of above 60, while if you look at even my country, Liberia, less than 5% of the population falls within the age category of 60 and 75 and 80. So that's a factor. And also, the built environment, traveling issue, air travel, and all of those things that are taking place as compared to low middle income countries. So government revenue, government needs to take ownership, invest in primary healthcare system that can detect diseases at the source and respond quickly. That's how we can stop the next pandemic or epidemic. Thank you.
Thank you very much, Tolbert. Excellent points. Over to you, Dr. Anna.
Thank you very much, Dr. Miki. I would like to say, I think that most of the questions have been answered, but just final notes. I think that building together is very imperative. And one of the key challenges, because these programs are anchored to government, it's important to do a lot of work with government rather than working independently as partners. Those ultimately threaten the sustainability and the resilience of the system. And overall, I would say that continuous learning and continuous monitoring and learning, doing a lot more of implementation research, not waiting till pandemics come for us to uncover all of these weaknesses in the system. And I would say as we prepare, I mean, I don't know about preparing because I mean, there is monkeypox and there's been different outbreaks in different countries for vaccine preventable diseases and all of that. So I wouldn't say we're far away from the next pandemic or the next disease of significance. And to be able to do that, learning sessions like these are important, sharing experiences across countries, but also resourcing. We can't run away from resourcing sustainably to be able to get this right. And yeah, ultimately it's being able to make those investments and making the case for them. And the final note is really, if at the end of the day, we're thinking about the users and the people that the communities or the citizenry that we're trying to protect, we need to build with them, we need to design with them, such that we can all own it and ultimately deliver what we want. I think those are the things that I've learned personally, and I continue to infuse into the work that we do. Thank you.
Thank you so much. Yep, I think those are also fantastic points, and you know, go to some practical strategies, but also just to also kind of the way that we work, which is a little bit less tangible sometimes, but incredibly important. So thank you. Dr. Mebratu, over to you for the last word from the panelists.
Thank you. Thank you so much. I think I already narrated more in my presentation, but just for as a takeaway message, which I learned in 2 years, is like leveraging the current capacity we had, as my brother said, the capacity we built for Ebola served us for COVID, and also the capacity we had today for COVID will really give us a leverage for going forward. So we need to not to ignore the capacity we built, and we need to build up over that. So that's one of the message I want to convene. And the other is investing in essential health service functionalities a must. We invested in HIV, we invested in TB, we invested in malaria. So that investment in infectious diseases really brought and helped us in the primary health care to really decentralize and manage locally the COVID. And Africa was not vanished because of the investment on those previous. And the other is building strong primary health care unit. So that's a must to have as a country. The countries you can see in the Asia or in Africa with strong primary health care systems, they really responded very well. We will see, and the historian will write, I believe, going forward. So the final word, all of government, all of society, all of the business. So the pandemics and epidemics of this magnitude cannot be challenged by the government only. So we need to collaborate, and this collaboration should grow up from the lower level to Africa and to the global level. Thank you so much.
Thank you, Dr. Mebratu. Great way to sort of wrap up the key messages here. Well, thank you all. Thank you so much to the panel for all of your perspectives, your insights, and all of the information that you've shared with us. Thank you to all of the participants for your engagement, for all of your excellent questions. We will be sort of collating the questions, and if there are some themes we didn't get to and some points to follow up on, we will do that. Please feel free to reach out to the course team as well if there's something that you really wanted to know more about and we didn't get to it today. If you joined this live session as a learner and you haven't actually been enrolled in the COVID course previously, it's still open, I believe, and I will pass to Tirsit or Biru in a moment to just say a few more words about being able to access that content that goes into some more depth on some of the themes that we've talked about today. And a huge thanks to the course team and to the team at the International Institute for Primary Healthcare for all of the work in developing this content, organizing the session, and continuing to provide these kinds of opportunities for connection across the region and to really learn from each other. So I will pass to Biru or Tirsit if there's any other logistical things or information you want to share with the learners, and then I think we can wrap up for today.
Okay. So thank you, Micah, for the nice moderation of the session, and for as well for the panelists for a wonderful experience that you have been sharing. So maybe one last announcement. This will be the last live session, or the final live session just prepare to wrap up our course. That is creating a resilient primary healthcare system, lessons from a COVID response from Ethiopia and other countries as well. So if you are have been taking the course, so this will be the final one. So you could complete your modules and take your certificate of completion starting from today. It is already ready. So we encourage you to finish the course contents. And also if anyone who didn't who were not registered and taking the course, if you are interested, group is already shared the link for the course registrations. So you could still join and take the course and get your lessons and experience from the course, and as well as certificate. So we encourage you to join us, and hopefully we'll be follow up with another other engagements in webinars and other courses as well. And thank you for being with us, everyone. Thank you. Over to you, Micah.
All right. Thank you, Tirsit. Thank you all. Thanks for staying with us a few minutes over, and have a wonderful rest of the day and talk soon. And bye, everybody.
Thank you. Thank you, Micah.
Thank you, Micah. Thank you very much, colleagues. Bye-bye.
Thanks, everyone. Bye.
Everyone.